So if you put an ice pack on a post-operative surgical site, and just leave it there for hours.
Which is, I mean, exactly what everyone instinctively wants to do.
Right, because you think you're doing a great job managing the inflammation, but your body's survival instincts will eventually just hijack your blood vessels, pump the area full of hot blood, and actively make your swelling much, much worse.
It completely defies our basic intuition about first aid. We're taught from childhood that when something swells up, you freeze it, to stop the process.
Yeah.
But human physiology is, well, it's far more defensive and reactive than a simple block of ice can handle.
And today we are decoding exactly how defensive the body can be. Welcome to this deep dive, specifically tailored for you, the listener. We've gathered a stack of really incredible source materials for this one.
We really have. We're looking at plastic surgery, recovery guidelines, clinical trials on cryotherapy, some deeply technical physiological studies on thermoregulation, and case reports from medical journals.
And our mission today is highly specific, but honestly, it's universally applicable. We are discovering the exact post-procedure ice application protocol that reduces immediate labial swelling.
Which is medically known as oedema, by the way.
Right, edema. But we want to reduce it without triggering paradoxical or dangerous vascular responses like cold-induced vascular constriction or rebound swelling.
Exactly. Because the biology we are about to uncover, it applies broadly to all tissue healing, but the perineal region is a particularly unforgiving testing ground.
It really is. Okay, let's unpack this. Because on the surface, putting an ice pack on a swollen area seems like the simplest thing in the world. You hurt, so you ice it.
Right. But the cellular biology happening beneath that ice pack is actually this delicate high-stakes balancing act.
So we have to start by completely unlearning the idea that colder is always better.
Yes. Colder is definitely not always better.
To understand why, let's establish the baseline. We apply cold because we want vasoconstriction, right?
Correct. When you experience trauma to a tissue, like during a surgical procedure, your body's inflammatory response just rushes blood and fluids to the area.
And that fluid leaks out of the capillaries and into the surrounding tissues, which is what causes the swelling.
Exactly. So when you apply a cold source, you activate cutaneous cold receptors on the skin, which fire signals up your sympathetic neural pathways. This triggers the smooth muscle cells wrapped around your blood vessels to contract.
They physically squeeze shut.
Yeah, the vessels narrow. That's the vasoconstriction. It increases the resistance in the pipes, effectively limiting that fluid leakage.
Got it.
It also it slows down cellular metabolism in the localized area, meaning the traumatized tissue demands less oxygen to survive the immediate aftermath of the procedure.
Okay, so the vessels clamp down, the fluid stops leaking, the swelling halts. I mean, that sounds like a perfect system.
It is, mostly.
But here's the biological plot twist. What happens if we drop the temperature of that tissue too low?
Well, we trigger a physiological phenomenon known as cold-induced vasodilation, or CIVD.
The hunting response.
Right, it's more commonly called the hunting response.
Right.
Research shows that vasoconstriction works beautifully, but only down to a specific threshold.
And what is that threshold?
If your subcutaneous tissue temperature falls below 15 degrees Celsius, which is about 59 degrees Fahrenheit, your body's emergency survival systems kick in and just override everything.
The body essentially panics.
Total panic. At that temperature, the smooth muscles around the blood vessels actually become paralyzed.
Yeah.
Or in some cases, the constrictor signals from the nervous system get completely blocked at the receptor level.
Wow.
And instead of staying narrow, the vessels are forced to dilate. They open wide up. In fact, if the tissue temperature drops all the way down to 0 degrees Celsius or 32 degrees Fahrenheit, the skin blood flow can become significantly greater than it was before you even applied the ice.
That is wild. Here's where it gets really interesting for you listening. It's like setting a house thermostat.
Oh, that's a good analogy.
Yeah, you want to cool the house down to a comfortable level to stop the swelling. But if you crank the AC too low, the house's internal sensors assume a blizzard has hit, so the emergency furnace kicks in and it blasts hot air through the vents, completely defeating the purpose.
Exactly. The body literally flushes the area with warm blood just to protect the tissue from freezing and dying. The autonomic nervous system will always prioritize preventing frostbite over preventing your post-operative swelling.
Okay, but wait. 15 degrees Celsius isn't actually that cold. I mean, if I put a gel pack on a bruised arm after playing sports, the skin temperature easily drops below 59 degrees Fahrenheit, and my arm doesn't suddenly flush with hot blood and swell up.
Right.
So why is the specific perineal tissue acting so drastically different?
It comes down to vascular and neural density.
Yeah.
The labia, and really the entire perineal region, they're built differently than the skin on your arm.
How so?
The area is incredibly dense with arteriovenous anastomoses.
Okay, that's a big term.
Yeah, it basically means specialized connections between arteries and veins that are highly reactive to temperature changes. And they exist for the sake of core body thermoregulation.
Oh, I see.
So when you trigger that hunting response in an area that is already incredibly vascular, you aren't just getting a small flush of blood. You are causing a massive rush to a delicate, actively bleeding surgical site.
Which sounds terrible for recovery.
It is. It leads to extreme throbbing pain and a much, much higher risk of postoperative hematomas.
Okay, so we've established that driving the temperature too low forces the vessels to blast open. But what if I just use a moderately cool pack, say right at that safe 15 degrees, and I just keep it tucked in my underwear all afternoon?
People try that all the time.
Right. Because I'm avoiding the freezing point, so I'm not triggering the hunting response. I should be fine.
No, actually, that approach walks you right into a completely different but equally dangerous physiological trap.
It is.
It's called the hysteresis effect.
Hysteresis. Okay, let's break down the actual mechanism of hysteresis, because the sources show it's not just a simple matter of the skin staying cold.
Right. We look at a really compelling study on cutaneous vascular conductance, which is basically a measure of how easily blood flows through the skin.
Okay.
They found that when you actively cool the skin for a prolonged period, the vasoconstriction doesn't just stop the second you remove the ice pack.
Wait, really? It keeps going.
Yeah. The receptors on your blood vessels, specifically the alpha-2C adrenergic receptors, actually change their behavior. Under prolonged cold, they become hypersensitized.
So they grab onto the constricting chemical signals and just won't let go.
Exactly. Even as the skin itself starts to warm back up to normal room temperature, those receptors are still clamping the smooth muscles shut. So the blood flow remains severely depressed long after the ice is back in the freezer.
There's a biological lag. The skin feels warm to the touch, but underneath the pipes are still sealed shut, which is depriving the tissue of oxygen.
And prolonged lack of oxygen is called ischemia. When tissue is ischemic for extended periods, it begins to die.
Oh, wow.
Yeah, this can lead to non-freezing cold injuries, tissue necrosis, or even nerve palsy.
Which is terrifying.
It is. The sources actually include an alarming clinical report from the Journal of Lower Genital Tract Disease. It detailed 2 cases where patients developed highly complicated vulvar edema and hematomas.
And hematomas are basically solid swellings of clotted blood deep within the tissues, right?
Yes, and when the clinicians investigated why these severe complications happened, the culprit was the overuse of ice packs applied directly to the perineum for comfort.
But wait, if you're in pain after a surgical procedure, your absolute first instinct is to keep the ice on constantly for relief.
Of course it is.
Are you saying that entirely natural instinct to manage pain is what can actually cause the exact complications we are trying to avoid?
It is. In those case studies, the patient's initial conservative management failed entirely because they were overusing cold therapy.
That's tragic.
It really highlights the danger. Prolonged, continuous icing caused such severe ischemia and subsequent vascular damage that the delicate postoperative tissue essentially broke down. The structural integrity of the vessels just gave way, leading to those hematomas.
So you cannot just wing it with ice based on how much it hurts.
Absolutely not. This is why a strict evidence-based protocol is non-negotiable.
Okay, so for you sitting at home recovering, how do you actually apply this safely? Knowing these biological traps, like the 15-degree rebound flush and the ischemic danger of hysteresis, we need to construct a strict protocol.
Right.
Let's look at the 3 pillars: the interface, the intervals, and the duration.
We have to start with the interface. That's the physical barrier between the ice and the body. There is a crucial warning pulled from the Power Plastic Surgery guidelines regarding local anesthesia.
This part blew my mind.
Yeah, immediately after a labiaplasty, or really any perineal procedure, the local anesthesia used during surgery fundamentally alters your sensation.
You literally cannot trust your own skin to tell you if it's getting too cold.
Exactly. Your nervous system's feedback loop is temporarily broken. If you apply an ice pack directly to the skin, you could easily drop the tissue temperature down to 0 degrees without even feeling the burning sensation of frost nip.
So a barrier is mandatory.
Yes. Therefore, you must use a barrier. A clean towel, thick cotton gauze, or wearing 100% cotton underwear between the skin and the ice pack. That barrier buffers the thermal transfer, keeping your tissue safely anchored in that therapeutic 10 to 15 degrees Celsius window.
Okay, so the barrier is the first line of defense. The second part is the intervals or the timing. How long should the ice actually be on?
The consensus across the clinical guidelines is very rigid here. It's 10 to 20 minutes on, followed by 20 to 30 minutes off.
Or I saw an alternative is 15 minutes of icing every 2 to 3 hours.
Right.
But why 15 minutes specifically? Let's unpack the biology of that exact window.
15 minutes is the biological sweet spot for two main reasons. First, it lowers the production of inflammatory cytokines in the local tissue.
And cytokines are basically chemical distress signals that tell the capillaries to become leaky.
Exactly. Cooling the tissue turns down the volume on those distress signals. Second, 15 minutes is enough time to physically slow down the conduction velocity of your A delta and C nerve fibers.
Conduction velocity, meaning the speed at which the pain signals travel up to the brain. It's like slowing down the electrical traffic on a nerve highway.
That's a great way to picture it. The A delta fibers carry sharp, acute pain, and the C fibers carry the dull, throbbing ache. Cooling them gives you that localized, numbing, analgesic effect.
But crucially, 15 minutes is not long enough to trigger the 15-degree hunting response.
Exactly. And taking a 30-minute break afterward resets those hypersensitive alpha-2C receptors we talked about to avoid the hysteresis effect.
Oh, I see.
Yeah, it gives the tissue time to gently reperfuse with warm, oxygenated blood before you clamp the vessels down again.
So it is entirely about controlled cyclical management rather than absolute restriction. Okay, we have the barrier, we have the 15-minute bursts. The third part of the physical protocol is the duration. How many days should you keep this cycle up?
The clinical sources are very aligned on this. This ICE protocol should be strictly limited to the first 24 to 48 hours post-procedure.
But hold on. I spotted a massive contradiction in the recovery timelines here. The sources say that post-operative swelling actually peaks between 48 and 72 hours. So why on earth would we stop icing at the 48-hour mark right when the swelling is literally at its absolute worst? Shouldn't we be fighting it the hardest right then?
It definitely looks like a contradiction,
Yeah.
but it perfectly illustrates the shift between the overlapping phases of wound healing.
Okay, explain that.
The first 48 hours represent the acute inflammatory phase. That's when active bleeding is a risk, and fluid is actively rushing into the interstitial spaces. Our primary goal is to minimize that initial influx. But after 48 hours, the physiological priority completely changes. The acute fluid leakage has largely stopped. The swelling you see at 72 hours is mostly just the fluid that is already trapped there.
Ah, so the goal shifts from stopping the flood to repairing the damage.
Yes. At that 48-hour mark, the body enters the proliferative phase. It needs to actively heal the surgical incisions by building new tissue. To do that, it requires a robust supply of oxygen, nutrients, and white blood cells, all of which are delivered exclusively by the blood.
So if you continue to aggressively ice past 48 hours to fight the visible swelling,
You are actively starving the healing tissue of the very resources it needs to knit itself back together.
that makes so much sense. If we are stopping ice at 48 hours because we want to promote blood flow for healing, I assume this is where the guidelines switch entirely to heat therapy.
They do. The protocols universally shift from cryotherapy to warm sitz baths.
Sitz bath.
Yeah. Sitting in a shallow, warm water bath reverses the process we've been talking about.
Yeah.
The localized heat gently dilates the blood vessels to purposefully increase circulation, flushing the area with those healing nutrients.
And it feels much better at that stage too, I'd imagine.
Oh, definitely. The warmth also actively relaxes the superficial pelvic floor muscles, which reduces muscular tension and secondary pain around the surgical site.
Okay, so day 1 and 2, ice with a barrier in 15-minute bursts to minimize the initial fluid rush. Day 3 and beyond, warm sitz baths to open up the vascular gates and let the healing begin.
That's the physical protocol in a nutshell.
But the body isn't a machine made of isolated parts. Your overall systemic state heavily dictates how your autonomic nervous system responds to local stimuli.
This is where the research gets incredibly nuanced. There are systemic variables that completely alter the efficacy of the ice.
Like what?
Well, the guidelines from Maholi regarding perineal cryotherapy point out a phenomenon we can call the digestive conflict. The guideline explicitly states you should never apply ice immediately after a heavy meal.
Wait, let's look at the cellular level here. What does a full stomach have to do with whether my blood vessels constrict around a surgical site?
It's an autonomic tug-of-war. Digestion is an incredibly energy-intensive process. When you eat a heavy meal, your body heavily activates the parasympathetic nervous system.
The rest and digest network.
Exactly. To process that food, the body purposefully dilates the blood vessels in the splanchnic bed, which is the vast network of vessels supplying your gastrointestinal tract.
So it's directing a massive amount of your total blood volume toward your core.
Right. You're demanding blood flow to the center of your body, opening everything up, while simultaneously putting an ice pack on a peripheral area, demanding the blood vessels to clamp shut.
So you are flooding the system with competing neurotransmitters.
Yes. The parasympathetic system is releasing signals to dilate, while the localized cold is trying to trigger sympathetic signals to constrict. This clash creates a direct conflict.
And who wins?
The digestion. The cold is fighting the digestive priority, and ultimately your body will override the localized cold signal to prioritize digesting the heavy meal.
Wow.
Yeah, the ice pack loses its efficacy entirely, and the conflicting signals can leave you feeling extremely uncomfortable and physically heavy.
So you literally have to schedule your icing sessions around your meals. You need to wait an hour or two after eating before you apply the cold.
Absolutely.
And there is a second major systemic factor highlighted in the sources, which is fatigue. The guidelines strongly advise against applying perineal ice when you are in a state of extreme exhaustion.
Which is tough.
Right, because let's be honest, after surgery, extreme exhaustion is the baseline. Why is icing while tired a physiological mistake?
When your body is severely fatigued, your hypothalamus, which acts as the brain's internal thermostat, becomes compromised in its ability to efficiently thermoregulate. Your body enters a protective, energy-saving mode. In this depleted state, the intense thermal shock of an ice pack isn't processed by the central nervous system as a helpful localized therapy. It is processed as a severe systemic stressor. It's just one assault too many for the system to handle. Exactly. Instead of localized vasoconstriction and pain relief, the cold acts as a systemic trigger. It can induce full-body shivering and chills.
And shivering burns energy.
It actually burns more energy and increases muscular tension across the pelvic floor, which is the last thing you want. Your nervous system is simply too tired to cleanly execute the localized constrictive response we want.
So you endure the discomfort of the ice without reaping the anti-inflammatory benefits.
Precisely.
So what does this all mean for you, the listener? It means recovery isn't just about localized treatment, it's a full-body event. You have to time your localized icing around your systemic functions, making sure you aren't fighting digestion or overwhelming an exhausted nervous system.
It's a massive shift in how to view recovery.
It really is. Okay, let's do a rapid-fire recap of the protocol so you can walk away with the exact biological blueprint. Step 1.
Step 1 is targeting the safe zone. You need the subcutaneous tissue temperature to stay between 10 and 15 degrees Celsius to prevent the hunting response.
Step 2 is the interface. Because local anesthesia breaks your sensory feedback loop, never apply ice directly to the skin. Always use a cloth barrier to buffer the thermal transfer.
Step 3 covers the intervals. Stick strictly to 15-minute sessions to lower cytokines and slow nerve conduction. This must be followed by at least 30 minutes of rest to prevent alpha-2C receptor hypersensitivity and prolonged ischemia.
Step 4 is the timeline. Stop the ice after 48 hours. Once the acute inflammation ends, transition to warm therapy like sitz baths to actively promote blood flow for the proliferative healing phase.
And finally, manage the systemic variables. Don't ice on a full stomach, and don't ice when you are deeply exhausted. Let your autonomic nervous system focus on one major task at a time.
Perfect. But before we wrap up this deep dive into the source material, there is a lingering, somewhat provocative concept we want to leave you with.
Yes. Everything we've mapped out today relies on physical triggers for vasoconstriction. Temperature drops, heavy digestion, severe physical fatigue.
Right.
But knowing that the autonomic nervous system is the absolute master controller of this entire vessel-constricting process, it forces a fascinating question about the mind-body connection.
How so?
Well, if psychological stress and postoperative anxiety trigger your sympathetic nervous system, your fight-or-flight response, how much does your mental state subconsciously alter how your blood vessels react to the ice?
Oh, wow. Does extreme anxiety amplify the vasoconstriction to a dangerous ischemic level before the ice even touches your skin?
Exactly. Could actively calming your mind, perhaps through deep diaphragmatic breathing, to stimulate the vagus nerve while you ice, fundamentally change the physical reality of your swelling.
That is incredible to think about. We spend all this time treating the physical tissue, but the psychological state might be pulling the vascular levers behind the curtain the entire time.
It's very possible.
It's a powerful reminder that true recovery requires managing the entire system, not just the isolated symptom. Thank you for joining us as we explored this fascinating biology. Keep exploring, keep questioning the seemingly simple things, and we'll catch you on the next deep dive.